Okay, so we have a next session, a next IC starting on, the topic is slowing down myopic progression. Essentially, myopia is becoming a form of a pandemic in itself. Currently, almost 30%, 25 to 30% of children in a classroom are wearing glasses. And I think in maybe another 2 decades, this is going to be 50%. So this is clearly something that's going to be something that all of us are going to handle. And so we thought we'll try and simplify all the options that we have to slow down the progression of myopia with the aim of finally reducing the complications of myopia, the retinal complications of myopia. And I think we've kept this IC at a sort of a basic level. We want all ophthalmologists to be aware of how one should go about these options. And so we are starting off with just a bit of etiopathogenesis of myopia. We're going to quickly jump into what we are here for, that is pharmacological interventions, which we'll be following with optical interventions. Dr. Prachi will be speaking to us about complications of atropine, and finally we're going to end with what will you do once atropine fails. So I'm going to kick it off with Siddharth.
Yeah, good morning everybody, and thanks for coming to our IC. Thanks Ashwin for including me.
Siddharth.
Yes.
Go there.
Bye. See, I feel like standing on the start line of a 100-meter dash because he's giving, I'll give you 12 minutes, not 1 minute more. So, good morning. And let me quickly start the talk. See, you need to understand few concepts in why myopia progresses so that you can correlate it with the various theories that have come up and various treatment options in myopia progression. So, for that, this etiopathogenesis in most diseases is very boring, but here in myopia it's pretty exciting. It's the nature and nurture both contribute to myopia progression. So you need to be predisposed to getting myopia. Only then the course of events in your life will eventually lead to myopia. So you can put two different children in the same situation. One who is predisposed to myopia will get the myopia, the other one will not get. So that's why you have lakhs of people doing the same kind of activity, but only few get myopia. You have 50 students in a class going through similar routines, but only few get myopia. So you need to be genetically predisposed. There is something in your genes that predisposes you to myopia. Plus, now that is aggravated or triggered by the environmental factors. Now, if you have one parent who has myopia, you have a 10% risk of developing myopia. If you have two parents who have myopia, you have a 25 to 40% risk of developing myopia. Certain genes have been correlated with high myopia. So there are certain genes which cause familial myopia, wherein most of the members of the family over several generations have got myopia. But those are not routinely the genes that you come across in your day-to-day this thing. Those are the genes related with high myopia. There are more than 100 genes correlated with high myopia and such syndromes. Now, what is emetropization? Let's get to the concept. When you are born, your eyes are small and they are not adapted to anything. Your eyes are closed. When you come out of the womb, you open your eyes. That is when the eyes start getting stimulated. And from there on, depending on what the stimuli is, the eyes starts changing shape. So, if you look at a newborn, you get wide variety of refractive errors. Okay. So in a newborn, you can have up to -8 or +8 or +4 cylinder, or very weird refractive errors you will get. Many times I have doctors who come with their children because they suddenly have done retinoscopy in their infant, newborn infant, and they are worried, okay, he has got +7, and they are really worried what to do about it. But that is how most infants are. Most babies are born with very weird refractive errors. Usually it is symmetrical. If it is symmetrical, don't panic, because gradually they are going to change. Now, most of the studies that have been done in myopia, we owe our understanding to all these friends, which are the chicks, the shrews, and the monkeys. And the studies were done in a very crude way in the olden days, where they used to stitch a lens on the eye of a infant animal and try to simulate a hyperopic or a myopic defocus. The other way was they used to just stitch the eyelids, close the eye completely, and see what happens when no light passes through or when a very blurry image passes through. So there are two types of studies. One is the form deprivation myopia studies, and then the other ones are the lens induced myopia studies. So what is hyperopic defocus? So if you stimulate a growing eye with a concave lens, obviously the image is getting formed behind the eye. That is a hyperopic defocus. Now when all these infant animals, the chicks, the monkeys and the shrews, when you created a hyperopic defocus in them, that means you created a image that was falling behind the retina went back. That means the sclera grew out, taking the retina with it in order to accommodate that image. So if you create a hyperopic defocus, you lead to myopia. That's how an infant eye grows. Because when a child is born, the eye is very small. The image is falling behind the sclera. So the eyeball tries to accommodate it. The reverse is also true. When they stimulated the eye of infant animals with myopic, their rate of growth regressed and it became slow. So the eyeball stopped growing as it would grow otherwise. In some lower animals, it actually shrinks also. And to prove the point, when they removed the stimulus and the infant is still growing, there is something called as recovery. So the eyeball stops growing where the other apparatus of the eye keeps changing in order to again bring the image into focus. So the whole concept is, if there is a defocus, the eye is going to change something in its structure in order to get that image right on the macula. Now surprisingly, it is not dependent on the afferent or the efferent arc that goes into the brain. So same effect can happen if you cut the optic nerve also. So even if the animal is not conscious of what it is seeing, the retina and the sclera can communicate with each other and send the appropriate signal for the growth. So it is that localized. In fact, there have been experiments where only a part of the retina, the lower part or the upper part, has been stimulated with the lens, and only that part of the sclera has bulged out. So it is that local loop that most of the therapies will be working on. Now, this is in short what I explained. So there is a visual stimulus, there is a defocus, there is a retinal response. Somehow the retina can talk to the sclera. It can stimulate the remodeling of the sclera, causing axial elongation. To certain extent, the same kind of defocus can happen if your accommodation is not great. So if your accommodation is not able to fulfill the demand laid on it, then again you will be having a defocus, and that itself can lead to axial elongation. So somewhere the same loop gets triggered if your accommodation is faulty. We'll come to that. So why does it progress even after correction? So my answer is, you would say, okay, defocus causes myopia. So the first time a child gets 0.5 number, you give 0.5 to the number. Now there is no defocus, so myopia should stop. But that is not how it goes. The moment you give glasses, next time the number goes more. So is this theory wrong? No, there is a modification to the theory, which is called the peripheral hyperopic defocus theory. Problem with your corrective glasses is that they correct myopia on the macula. What about the periphery? In the periphery, because the sphericity of the lens, the image is still getting focused behind the retina. So that is called a peripheral hyperopic defocus. The same was proven by Mr. Earl Smith in his experiments, where he burned the macula of the monkey and he gave them a negative stimuli, that is a concave lens. Still the eyeball grew. So that means the image on the macula is not important. It is the image on the periphery of the retina which is important. So we come to the point that it is not only the image in the macula, but also the image in the periphery that has to be focused. That is where our modern DIMS lenses come into the picture, or orthokeratology comes into the picture, which my colleagues will be covering. Now there are so many environmental risk factors. near work. So if a child is studious, he gets glasses. In the olden times, the scholar guy or the the child getting first rank used to always have glasses. All the doctors have glasses. All the people who are studious have glasses. Children in urban areas have glasses. Children in rural areas don't have glasses. Children in advanced countries, industrialized nations, countries where the income is more, they have glasses. So what does it all show? It is somewhere related to near work. So when it comes to near work, you need to accommodate in order to focus the image on the retina. Now if your accommodation is faulty, it is laggy. Laggy means what? You want suppose 2 diopters of accommodation, but your eye is only able to provide 1.5 diopter of accommodation. There is 0.5 diopter of accommodation which is lagging. So that itself is creating a hyperopic defocus, and that can lead to progressive myopia. So it's accommodation lag that can lead to, that is where bifocal glasses and progressive glasses were supposed to help. So if you give somebody who is increasing in number, if you give him bifocal or progressive glasses, that takes care of the accommodation part, and that will take care of the progression in myopia. This is in theory. In practice what happens, they will talk. Now when you talk about atropine, again, biggest misconception is that it works by relaxing on accommodation. Okay, but atropine works on the muscarinic receptors. In chicks also it works. In atropine, if you give to a chick's eye, it will stop progression of myopia. Chick's eye ciliary muscle is actually a skeletal muscle. It does not have muscarinic receptors. So that's why, it doesn't have nicotinic receptors. So it doesn't work on any kind of accommodation. It works on the scleral remodeling. So atropine, when you are giving in low dose, don't substitute with any other cycloplegic agent. People feel that if you are not getting dilute atropine, you can give cyclopentolate or you can Hopic, because anyways it is also going to relax accommodation, but that is not how atropine works. How atropine works, again one of us will cover. So that is more or less when it comes to the etiopathogenesis of myopia progression. Should I stop here?
Yeah, I think so.
Thank you.
Yeah.
I will go to the next lecture.
So I'm going to speak about essentially the mainstay of intervention for progressive myopia, and that is pharmacological control. So atropine has been around for more than 8 or 9 decades, but this new indication is essentially, it's like an old car with new tires. It's just doing something else for us now. The exact mechanism we still do not know, but we know that it doesn't work on accommodation, as Dr. Siddharth said. It is a non-specific muscarinic antagonist, so essentially it blocks the muscarinic receptors, and there are some of the theories that tell us how it may be working. So it's possibly stimulating some neurochemical cascade on the M1, M4 receptors in the retina. That's one of the theories. Another theory is that it possibly inhibits the synthesis of glycosaminoglycans at the level of the sclera. And there's also a theory that it acts on the dopamine at the RP level, which cancels the retinal signals for eye growth. So these are some of the possible ways that atropine works. One of the other drugs that has also been studied is a specific muscarinic receptor called pyrinzipine. It was used as a 2% gel. The difference being it's a specific antagonist, so it had minimal effect on cycloplegia and dilation. But a lot of these patients, there are 2 big RCTs on pyrinzipine, and they found that it reduces the myopia progression by almost 50%. So this is not available still for clinical use, but this is a potential drug for the future. So these are the 3 main actual studies which is, taught us about atropine and tells us that this works. So I'm going to sort of simplify these studies by just talking about the main conclusions. So the ATOM-1 study, which was published in 2009, or more than a decade ago, tested 1% atropine. This was used in 400 kids, and they found that this worked very well. These children hardly progressed, So over 2 years, they progressed by 0.28. That is almost 77% reduction. This also showed in the axial length growth. But the downside of 1% was that you essentially had to prescribe some form of bifocal or progressive and even photo gray glasses. And the second big drawback was that as soon as we stopped this, there was a significant rebound myopia. Rebound myopia essentially means that as soon as you stopped it, the myopia just progressed much quicker than even the control group, which was not having any drops whatsoever. So they realized that probably 1% works well, but there are too many side effects. Let's look at some other concentrations. So then they did half the concentration, 0.5, 1/5 of that, and then they jumped straight to 1/10 of that, that is 0.01. It was a good study because it was a long-term study, it was a 5-year study. They used the control, they didn't have any placebo group. So they used the Atom 1 ka placebo. So that was a drawback to it. But let's come straight to the results. They essentially said that 0.01 works very well. They realized that the stronger the concentration, better effect, but less the rebound. So they concluded that Atropine 0.01 has minimal side effects, but it has a comparative efficacy. This is a very common sort of graph you may have seen, but I'll tell you what this is. This line going down, we have myopia on this axis. So this line going down saying that this patient is becoming myopic. This is the line that was the placebo, which kept on progressing over 2 years. This top line is the 1%, which in fact for some reason got better, but still progressed very minimally for 2 years. And these are the other concentrations we spoke about. This is 0.5, 0.1, and 0.01. So at 2 years, they found that these were quite similar, but as soon as we stopped the drop, this 1% dived right down and increased. That was the rebound effect of 1%. While the 0.01 almost had no rebound. So they said at the end of 3 years, if you had to give atropine and then stop atropine, you'd be better off giving 0.01 rather than giving 1% and then stopping, because you're in a better situation with 0. So that's how they concluded that 0.01 is pretty good. So that's where, the whole thing came up, that we are going to start using 0.01, and for the past at least now 7 or 8 years, it's become a mainstay of practice as that being the drop of choice, and that's available in our armamentarium. Then came the LAMP study. Okay, so the first phase of the LAMP study was published, in which they said, there was that 10 times difference between 0.1 and 0.01, which was tested by Atom. So they said, let's test the in-between percentages. So they said 0.05, 0.025, and then 0.01. And this one had a placebo group. So again, let's just look at the conclusion of the 1 year. At 1 year, they found 0.05 was the most effective. That was the strongest drop. 0.05 was the most effective. And this time they found that not only was it effective for spherical equivalent, but it also helped the axial length. It also showed on the axial length. So yes, this was a drop that was found to be most effective. They continued this study for the second year. This was published in 2020, and they found that the same result was seen, 0.05 being the most effective. So the efficacy of 0.05 in comparison to what we use 0.01 was double, where 0.05 progressed by 0.5 and this progressed by more than 1. So this was telling us there's one more concentration that may do the job for us, maybe slightly better. And now just 2 months ago, they published the 3-year data. This is a busy slide, so don't read the slide. I'm just going to just tell you the brief what the 3rd year study said. The 3rd year study wanted to check rebound effect. They have proved that 0.05, which is 5 times more than 0.01, is more effective. But does it have a rebound effect if we stop it? That's what they wanted to know. Just like how 1% had a great rebound effect. They found that yes, the stronger the drop, more the rebound effect. But they found that 0.05 had a clinically insignificant rebound effect, which meant that if you kept someone on 0.05 and kept someone on 0.01, then you stop them both. You check the rebound, and check them at the end of rebound phase, 0.05 was still 0.75 less in power than 0.01. So are we looking at another concentration that we should be thinking of? So this is just a summary of all the studies. As you can see, going from 1% going down to 0.01%, the effect of myopia, the effect of preventing progression keeps on reducing. But the first three, 1, 0.5 and 0.1, they all affect the pupil significantly. So they do need progressive lenses. These last three, most of them don't need anything. So higher the dose, the better it is. But higher the dose, more the pupil dilatation, and also more the rebound. So we have to just try and find that in-between dose. So is 0.05 that dose is the question. It's still not come into practice. We are still using 0.01. We're trying to increase the concentration. So some of us, if the patient doesn't respond to 0.01, we do go into 0.01 twice a day. There are no studies on that, so we don't know whether that's the right thing to do. And plus 0.05 is not available, so if we want to use it, we'll have to reconstitute it from the 1%. So I'm just going to briefly spend 2 slides to tell you what I do, or what most of us do when a patient with myopia comes in. We definitely take parental history of myopia and retinal detachment, and in siblings as well. Check vision subjectively in an older child, but all of them should have a cycloplegic refraction. Perform axial lens definitely as a baseline before you start atropine, and once a year. And look at accommodation, look for accommodation lag. So the high risk factors where you want to treat with atropine more aggressively will come out of this. If you have a family history, if you have an early age myope, if you have accommodation problems, these patients, we know atropine needs to be used more aggressively. So how will we use atropine in these patients? First of all, don't start atropine in every myope that walks into your clinic on the first day. You want to know whether he's a rapid progressor. So I typically follow them up for about 8 months at least, if not 12 months, and calculate a rate of progression by doing cycloplegic refraction in at least one of those visits, if not both. If the progression is 0.75 or more in a year, if you can calculate that, then I would start the drop. Once at night, review them 4 monthly, and in a year you would know whether this is working or not. If he is 50% less than how he was progressing before, then it's working, which means he's a responder. If it's not, then he's a non-responder. Close to 20% of patients are not responders. So if they're non-responders, then consider adding a therapy or replacing the therapy. And Dr. Pooja is going to talk to us about that. We would stop the drop if you get an allergic response, if the patient is a non-responder. If you've had 2 years of treatment, you can look for a washout period and see whether they're still progressing, or if the child is, reaching the end of growth phase, which is about 15. So I'll stop there, and I'm going to have the next talk by Dr. Anand Kumar. He's going to speak to us about optical and lifestyle interventions for progression. Anand, can I stop you there? So sorry. I think it'll be more relevant if you do. So I'm just going to change that plan a little bit.
Oh, you're snatching the mic away from me?
Yeah, I'm so sorry.
Oh.
So I thought it'll be relevant for Dr. Siddharth to speak to us for about 5 minutes. Thank you. He's going to talk to us about a consensus that a group of pediatric ophthalmologists of Mumbai came up with and was published. It was one of the first publications on a consensus of atropine use, and this sort of will tell us how we are using it right now.
The time barrier is like a hanging sword. I'm very scared of time always. But here I wouldn't be elaborating on much because these are guidelines. So I just have to read it out to you. ये क्या हो? Oh sorry, इधर कर दो. Slide show में जाना.
Press paste down.
नहीं. No, he's controlling the thing. Yep. मैं कर रहा हूँ. अच्छा, it's not coming here. So while he brings it on, this was an exercise we did in 2018 actually, when Atropine was still new, where we wanted to know if we can reach some consensus on how to use it, because everybody was trying to use it and there was not much going around how to use it, and everybody had a little bit of a different pattern on its usage. So in order to like streamline things, we went through the Delphi process of collecting data and then made a consistent guideline. So just for introduction, GPOS is a group of pediatric ophthalmologists and strabismologists based in Mumbai. Almost 40 of us are there, and we meet regularly and talk about different issues in pediatric ophthalmology. So in this study, there was review of literature, and there were 26 people present in that. There was review of literature, 2-3 of us presented the available data. There was a group discussion followed by formulations of certain questions on which we wanted what everybody is doing. Then this set of 30 questions were circulated via email to the group, and the responses were studied and tabulated. And then we tried to see, okay, what are the things that are done similarly by everybody, and on what issues there is a difference of opinion. Then we got together in another meeting, and then we tried to iron out the differences. So all the things that got 80% approval came into the consensus guidelines. So that is how we reached this consensus on how to practice. Overall, this was the only available consensus guideline at that point in time. It got published in the Indian Journal of Ophthalmology, April issue of 2019. Until very recently, this was the only guideline available, and now AIOS has done a similar exercise and come with a new guideline which was released very recently and is being circulated widely in this conference itself. So certain things have changed and certain things are same. So the results from the questionnaire were that most of the pediatric ophthalmologists have started using Atropine in their children who are progressing with myopia, and 65% of the respondents were giving it for children who are older than 5 to 6 years of age, and 88% respondents were giving it up to the age of 12 to 14 years of age. The starting point varied from person to person. There was no consensus on that as far as the questionnaire was concerned. Respondents also reported that sometimes they are flexible in starting Atropine, sometimes they start in the first visit itself because the parents might have myopia. There was no consensus on the duration of therapy at that point in time, and most of the respondents have some sort of target myopia and refraction in their mind. Okay, if we reach this rate of progression, we might stop it and see. Majority of the respondents call their patient after 6 to 8 weeks from initiation of therapy to look for any side effects and compliance, and 60% of the respondents see their patient 6 monthly. Majority of the doctors in the study use implied consent, only a few were using written consent. Majority felt that a cycloplegic refraction was important in every visit, and 75% felt that axial length should be included in the workup to document progression. More than 50% doctors limit the use in simple myopia only. 80% feel that there may be a case for starting the higher concentration and moving to lower concentration, and 60% respondents feel that there is no need for tapering the dosage. You can stop it suddenly. Based on this group discussion and this questionnaire response and then the meeting, we reached a consensus statement. The consensus statement said that it should be offered to children with progressive myopia. Progressive myopia is not same as pathological myopia. It is simple myopia which is progressing, and it is a reasonably safe intervention. So we formulated certain guidelines based on the meeting that we had and the questionnaire response. Children between ages 5 years to 14 years may be routinely offered treatment. Ages lower than 5 years or above 14 years can also be started on treatment depending on your discretion and their risk factor, because it is well known that early onset is associated with faster progression. Any subject who is progressing by more than 0.5 diopter in a year or more may be offered myopia control. lower cutoffs in children with strong family history of myopia progression, especially with early onset. If a child has both parents as myopic and he is starting off at 5 years of age, he is starting to become myopic, you can start myopia, this atropine even at an early age. And higher cutoffs may be used for children whom myopia had a late onset. Target refraction should be kept in mind. The group recommends counseling of caregivers before starting therapy. So you have to spend some chair time talking to the parents what it is all about and how it works and how long they are expected to put it and if what they are supposed to report. The group recommends that written informed consent be taken before starting therapy till the time the treatment gets wide acceptance at the standard of care. Till that point in time in 2018, only few of us were using it, and that's why this guideline was there. This guideline is no longer practiced by any of us. So because it is now widely used, we don't take a written informed consent. Initiation and duration. A basic cycloplegic refraction and axial length measurement should be noted in the first visit, that before starting therapy, and the first follow-up after starting therapy is recommended at 2 to 3 months of age. This is to use just to look at whether there are any side effects, and 6 monthly follow-ups are suggested, and cycloplegia should be used in case there is any progression. If the power is same, you need not use cycloplegia. The therapy is continued for at least 2 years. Mind you, it takes almost 6 months to 1 year for atropine to start progress, showing some effect. I don't know if you remember the graph that he showed. In the first 6 months, there is no change in rate of progression with 0.01% atropine. So in the first 6 months, they will come back, they will have the same rate of progression, more or less. It takes almost 1 year for it to start. So continue for at least 2 years before you say, okay, the person is responding or not, and whether you should continue further or not. At that point in time, we did not have access to the 5-year data. Now you can safely continue it up to 5 years and then try and stop it. Members recommended the use of commercially available 0.01%, obviously because there is no other option. There are children who will continue to progress in spite of this therapy. Who are the progressors? Anybody whose progression is not reduced at least to 50% of their initial rate of progression. A child on atropine 0.01% drops may rarely complain of allergy, blurry vision for near photophobia and headaches. This may require use of tinted bifocal glasses or discontinuation of therapy. Even in ATOM, there were almost 6% patients who on 0.01% atropine had photophobia and they could not read properly. So in some children, they might still require progressive glasses. It is not recommended in the presence of any other ocular systemic comorbidity or atropine allergy. So if a child is otherwise healthy, only then I start it, because I don't want it to interact with any of his other diseases or medication. May use it in conjunction with myopia control interventions like spending time outdoors and orthokeratology. So there are other myopia control measures which Anand will be talking next. You can use it in there is a additive effect to that. Currently the use should be limited to simple myopia only. Please take home this point. It is only for the garden variety of school myopia. It is not for pathological myopia. It is not for congenital myopia. It is not for ROP related myopia. It is not for pseudophakic myopia, not for index myopia, not for cataract myopia. It is only for simple school myopia. Non-respondents are occasionally encountered and may be shifted to higher concentrations of atropine or other forms of myopia control. So if somebody is not responding, you can shift to a higher concentration like 1% and put them on presbyopic correction, near vision correction.
Siddharth, can you summarize?
And, I think that's my lifestyle. Thank you. So those are the guidelines and they will elaborate on it. Thank you.
So Dr. Anand Kumar will speak to us on optical and lifestyle interventions for myopia progression.
Thank you, Ashwin. Thank you, Siddharth, for that wonderful prelude to my talk, which is the main highlight of this session. So I'll be speaking on the optical and lifestyle changes to control myopia. Apart from the pharmacological intervention, which Dr. Ashwin very nicely elaborated upon, there are certain environmental modifications and optical devices which have been found to prevent myopia progression. Among the environmental modifications, the best and probably the most effective intervention is increase in the outdoor activities. Many studies highlight the protective effect of outdoor activities. In a recent meta-analysis, it was found that every additional hour of outdoor time per week led to a reduction in the risk of myopia by 2%. And that's a huge figure, believe me. In another study, it was found that the chance of becoming myopic is reduced by around 1/3 if the time spent outdoors is increased from 5 hours to more than 14 hours per week. Now, how does this act? The mechanism of increased outdoor time is not completely clear. However, it is strongly suggested that it is the time spent outdoors itself rather than doing physical activities outdoor, which is the protective factor here. It is thought that the three-dimensional structures of the outdoor environment possibly form some specific defocus patterns on the retina, and this is protective against progression of myopia. The protective effect of outdoor activity is at least partly light mediated release of dopamine from the retina. Like Dr. Ashwin mentioned, that increased dopamine levels are known to inhibit axial elongation. Also, the absence of ultraviolet light indoors may provoke axial myopia. According to Flitkoff, he proposed that the spatial frequency composition of man-made environment are very different from those of natural environment, and it is these frequencies which may be provoking myopia progression, and hence enhancing spatial frequency of the visual scene may be protective against progression. The evidence points that outdoor activities are more protective against onset of myopia rather than progression of myopia in a child who already has myopia. Wu, in a set of Chinese children, found that participation in outdoor activities during school recess had a significant effect on myopic shift in non-myopic children, but not so much in children who already have myopia. In another study, Jones found that there was no effect of near work or time spent outdoors on the progression of myopia in those children who already had established myopia. Hence, it is always better to promote outdoor activities in children before they go on to develop myopia. However, there have been other studies which have shown that faster myopia progression occurs during the darker winter months than the brighter summer months. This may indirectly point that outdoor activities or sunlight may have a protective role even in myopic children. A number of studies have reported lower levels of vitamin D in myopes compared to non-myopes. And lower vitamin D3 levels are known to be associated with longer axial length, higher risk of myopia in young children, and this effect was independent of the outdoor exposure time. However, there are some contrasting studies. It was found in a study that total vitamin D and D3 levels are just biomarkers for the time spent outdoors, and there was no evidence that they were independently associated with future myopia development. Also, in a study by the CREAM consortium, a Mendelian randomization analysis did not support a direct involvement of vitamin D with myopic refractive error, as it was found that genetically predisposed children to vitamin D deficiency did not become more myopic as compared to the other children. Hence, the role of vitamin D in preventing myopia progression is not very well established. Now, what about indoor lighting? It has been found that increasing the light levels from approximately 100 to 500 lux in school classrooms had a significant effect on myopia onset, refraction, and axial elongation. In another study, in a group of Chinese children, it was found that time spent with a light intensity of more than 3000 lux was a protective factor for myopia in China. So brighter the room, lesser would be the progression of myopia. Does the type of indoor light play any role? It was found that use of the more commonly used these days LED lamps was associated with more refractive error and longer axial length. So this may come as a surprise to most of you. In fact, there is a French regulatory agency which recommends avoiding the use of LED light sources in places frequented by children, as it may cause possible photochemical damage and photoreceptor loss. So among the environmental modifications, there is strong evidence that less near work and more outdoor activities provide protection. It is the time outdoor itself rather than the physical activity which is the protective factor, and the link between time outdoors in prevention of myopia is much stronger than the link between time outdoors and slowing of progression of myopia. Now coming on to the optical measures, undercorrection of myopia with glasses has been a very common practice since many years. The theory is that it reduces myopia progression by reducing the need for accommodation. However, current evidence suggests that this might actually be harmful, as undercorrection does not provide optimal distant visual acuity, and this may lead to a reduction in outdoor activities in some children. In contrast, undercorrection has also been shown to promote myopia progression. More recently, a specially designed spectacle lens called the DIMS, or the Defocus Incorporated Multiple Segment, has been used for control of myopia. The lens design has a central optical zone which is used for correcting the myopic refractive error, and it is surrounded by multiple segments of a fixed myopic defocus of plus 3.5 diopters. This enables the lens to provide a clear as well as a myopic defocus when the child is looking at all distances, be it a distance, intermediate or near distance. So this spectacle is based on the peripheral defocus theory. Like Dr. Siddharth mentioned earlier, in a myopic eyes, the light rays are focused in front of the retina and in the periphery behind the retina. When we use a conventional single vision lens, the central rays get focused onto the retina, but in the periphery they get focused even behind the retina, causing a hyperopic defocus, which is thought to be promoting the myopic progression. The DIMS technology creates a myopic defocus in the periphery, and this is known to slow down the myopic progression. So Lamb studied the effect of these glasses in children of East Asian ethnicity and found very good results. There was less myopia progression in 52% of kids, less axial elongation in 62% of kids, and almost 21% of children showed no myopia progression whatsoever. Same group of children were followed up for 6 years, and similar effects were maintained. And when these children stopped wearing the DIMS lenses and switched over to single vision lenses, their myopia progression was much faster than the children who continued wearing DIMS lenses.
Anand, you have about a minute.
Yeah, thanks Ashwin. So some years back there was the use of progressive additional lenses. They allow the child to see objects clearly both at distance and near, and this works by reducing the accommodative effort. These lenses had a mild to moderate reductions in myopia progression, and they were soon overtaken by other glasses such as the DIMS glasses. Since the last few years, multifocal or bifocal contact lenses have also been tried out, and they have been found to be pretty effective. They slow down myopia progression to the tune of 30 to 38%, and axial length reduction, prevent axial length growth by around 30 to 50% over a period of 2 years. A commercially available contact lens, MySight, is a daily disposable multi-zone design contact lens, and it produces lower myopia progression by around 60% and lower axial growth of the eye by around 50% as at 3 years compared to the spectacle use. So just to summarize, among optical measures, results for dim glasses are very promising, and there is benefit with moderate certainty for the MySight contact lens and orthokeratology, which Dr. Pooja would be speaking about in greater detail. Thank you.
Thank you, Dr. Anand. I'm going to invite Dr. Prachi Agashe to speak to us about complications, side effects of pharmacological interventions, mainly atropine, and what do we do then? Yeah.
A very good morning to everybody. Thank you, Dr. Ashwin, for having me on this IC. So the topic is contraindications and complications or side effects of atropine treatment. So I'm going to try and cover the areas where atropine cannot be used. The slides are not moving. Thank you. So by now it's well established that atropine drops are a very good treatment modality for controlling myopia. However, is it a single step fix for control of myopia in all the cases? Let's try to understand this through some case examples. So I've just tried to put down clinical scenarios which we actually encounter in our clinics. So a 1-year-old presenting to us with history of holding toys very close to his face. The cycloplegic refraction revealed a refractive error of -8 diopter sphere in both the eyes, and the fundus is as shown in the picture with a tilted myopic disc, a parapapillary atrophy and a tessellated fundus. The child has been following up regularly. At 4 years of age, the refraction is still stable. What is this type of myopia? I'll give the answers later on. Just have these clinical findings at the back of your mind. Case number 2, a 6-year-old girl presenting with difficulty in seeing the blackboard. Unaided visual acuity was 6/18 and the cycloplegic refraction revealed a refractive error of -1 spherical error. The child has been following up. Over the next 3 years, the myopia has progressed to -3.5. So what is this type of myopia? Case scenario number 3, 8-year-old child, known case of high myopia on glasses since 2 years of age. Current prescription that the child is wearing is -8. Parents still feel that the child has started holding things closer to the face and the glass power has increased, and they were right with the cycloplegic refraction having progressed to -11. The child had a fundus which is again as shown with the myopic disc, parapapillary atrophy and myopic maculopathy. So what is this type of myopia? Last case scenario, 7-year-old child presenting with diminution of vision for distance with an unaided visual acuity of 6/24. Dry autoref readings are -3.5, however have been slightly variable. But on cycloplegic refraction, there is no myopia. The child has a spherical error of +0.5. So what is this type of myopia? So case 1, where the young child had a very high myopia and it remained stable till 4 years of age, this is a case of congenital myopia. So atropine drops should not be used for these patients because they do not progress further. Case number 2, a 6-year-old child who progressed over the next 3 years. This is a case of simple or developmental myopia or school myopia. So this is the cohort wherein atropine works. And these are the patients who can be treated with atropine eye drops. Case number 3, where the young child progressed from -8 to -11 with pathological fundus changes. This is a case of pathological myopia. Again, atropine is contraindicated and should not be used for these patients. Case number 4, any guesses? This is a case of accommodative spasm and there is no myopia. So there is no role of atropine drop. So just make sure that a cycloplegic refraction is done for every patient, at least in the first visit, before you label it as myopia and think of treating this child. So the types of myopia that we know are axial, wherein the axial length elongates, curvatural, where the myopia is attributable to the corneal curvature, positional, which could be due to the position of the lens, and index, which is lens induced, as in diabetics or in lenticonus. So atropine again has to be used only in cases of axial myopia and cannot be used in other types of myopia. So these are the contraindications. Okay, so atropine, as I said, is effective in controlling axial myopia and not in the other types of myopia, demonstrated through the case examples. Now we know atropine 1% eye drops leads to a dilated pupil. It causes suspended or loss of accommodation. It causes near vision blur, photophobia, and mydriasis related phototoxicity. However, this was a meta-analysis that was published in 2017, which actually analyzed almost 17 papers, which showed a very good result with atropine 0.01%, which we are using, with very minimal effects on the photopic and the mesopic pupil size, with an increase to just 0.3 to 0.6 millimeters, and very negligible effect on the accommodative amplitudes. So it was a very small percentage of kids who had any effect on their near vision in the group that were using the low dose atropine drops. Allergic reactions have been reported with these drops. The allergy could be ocular or periocular. It was more common when the 1% eye drops were being used, or when the low dose drop was reconstituted from the 1% drop. So initially, when the commercially available drops were not available, we were actually mixing the atropine drops with refreshed ears and were prescribing to patients. The good part, so they presented in the form of lid crusting, periocular erythema, or papillary reactions as shown in the images taken from the article. The patients responded well with discontinuation of therapy along with steroid ointment, and changing over to low dose commercially available atropine drops seemed to do the trick. The effect of atropine drops on the posterior segment. So we learned through the earlier presentations that the 0.01% atropine drops, one of the hypotheticated mechanisms is working on the dopaminergic system and causing an increase in the dopamine levels through the RPE. Hence, it was thought that it can affect the retina, and hence pattern ERG amplitudes could be modulated by the changes in the retinal dopamine. So, few studies are there on this. However, this the ATOM study did not notice any significant changes in the full field and multifocal ERGs after 2 years of use. This was a study again done by Dr. Mihir Kothari, where they had just studied 2 subjects, one myopic and one emetropic, where 4 drops of 0.01% atropine were administered in either in one eye and tropicamide in the other, and full field pattern and multifocal ERGs were obtained at baseline and after 45 minutes. They reported profound reversible reduction in the P50 amplitudes without reduction in the implicit time in the pattern ERGs, as is shown in the figure. However, there is a study that is contrasting to that and probably more recent, where the 14 participants were studied, wherein 0.01% atropine was administered daily for 14 days. 2 sets of steady state pattern ERG was recorded. One was a different contrast and one was at different check sizes. This study reported a small increase in 6% of the amplitude difference between the contrast levels with atropine application, but was not significant. And this particular paper suggested that the retinal processing as reflected by pattern ERG does not sizably change. The implication of this is probably just be wary of giving atropine drops in patients who have some night blindness or some other retinal dystrophy, because it may variably affect the ERG. Then effect of low dose atropine drops on choroidal thickness. This was a paper that's reported that 0.01% atropine alone caused a significant increase in choroidal thickness. It also studied the effect of the hyperopic defocus glasses, which reported a decrease in the choroidal thickness. And when both were combined, the hyperopic defocus glass as well as 0.01% atropine, there was a smaller magnitude of choroidal thinning. Now, whether this is really clinically relevant to us is not very, very clear, but requires further investigation. Effect on the ocular biometry. So we looked at the results from the LAMP study, wherein we saw that 0.05% has the best effect on controlling the axial length. However, the effect on other biometric parameters was pretty stable. So the corneal power remained stable across all groups. The lens power decreased slightly across all groups, while the AC deepened equally across all groups. Effect on the muscle balance. A convergence excess consecutive esotropia has been associated with 0.01% atropine drops. Again, this was reported by Dr. Mihir Kothari et al. In 3 patients who had undergone surgery for intermittent exotropia. A good result was obtained post-operatively where they were microtropes. And on starting 0.01% atropine for myopia, they developed a convergence excess esotropia with high AC by A ratio. However, the good part was that the effect reversed completely on cessation of treatment. So all the side effects that I have just enumerated should be looked for when the patient is called for a follow-up in the first 2 to 3 months after starting the drops. So to summarize, pupillary dilatation and accommodative insufficiency are very common with 1% atropine drops but has a negligible effect with the low dose drops. Ocular allergies were again common with the 1% eye drops and the reconstituted eye drops from 1% drops, but less with the commercially available drops. Effect on pattern ERG is not very clear, but we should be wary of prescribing it in patients having some retinal issues. Subfoveal choroidal thickness increases with 0.01% atropine, which requires further investigation. And it may induce a convergence excess esotropia, so may ensure to do a cover test when you see the patient for a follow-up. So overall, this is a very safe and effective treatment option. Though I have mentioned the side effects, the percentage that we come across is very, very less and is a very, very good effective tool for controlling myopia. Thank you.
Thank you, Dr. Prachi. I now invite Dr. Pooja, can you come to this one, please? Yeah. Dr. Pooja Gala Gogri, she's going to speak to us about the non-responders. What do we do when atropine fails?
Good morning, everyone. So at the outset, I would like to thank Dr. Ashwin to give me this opportunity. And when we are discussing this topic we've heard about atropine working very well, but what do we do when it fails? And myopia progression is a real concern in the current day and age. So the reason we're even discussing this is because all the current studies have shown that there is about a 12 to 15% children who are either slow responders or non-responders to atropine. So we said that if myopia progression is not halted by about 50% using either low-dose atropine or atropine, we will either label them slow responders or non-responders. I'll take the talk through causes, alternative therapies, additive therapies, the experience that we have at our clinic, and newer therapies that we can look forward to. So coming to the causes, we need to start investigating and definitely begin with the history and examination. And why history? Because we do know that children who are younger and those who have a higher myopia at onset and children who have parents with high myopia or myopia are known to be progressors, faster progressors, and have a higher risk. Lifestyle modifications is essential to know because it is the safest strategy to still control myopia progression. We cannot ignore it. We must spend some time to actually advise it properly so that the parents and the child know that it's significant. If they're not following it, we must keep reinforcing it at every visit. Go to the history of the method of the drop installation for the atropine drop. Ask the parents, how is the drop instilled? Sometimes we may see that one pupil is better dilated than the other if the child is on a 1% atropine drop. And if one drop is not working well in one eye, either because the child decides to turn his face and the drop is washed out, or the child cried or had excessive tearing, there could be a failure to the drop installation, which is not actually a drug failure. So if that is probably the cause, we need to make sure that we teach them how the drop needs to be instilled. This can be done by telling them to lie down straight, use a tissue paper, instill one eye before the other eye, keeping some time in the middle, dab the excess drop out. One day you can start with right eye first, left eye second. The next night you can use left eye first, right eye second. If we know that the drop is instilled correctly, and there is myopia progression, then we may consider this case as a case of drug failure. Also, it's important to know, why do we have to look for the next line of management? Is it an allergy to the drop? Is it some contraindication or a complication? Coming to the examination, often binocular vision anomalies are also responsible for progression of myopia. So like Dr. Siddharth discussed about the causes of myopia progression in the pathogenesis being accommodative lag, or those patients who have a near esophoria, we need to look for those and treat it accordingly. In patients who have ROP or syndromic babies, we must ensure that these are not actually progressive myopes which we can treat, but make sure that we are sending them across for their genetic evaluation or the pediatrician for systemic evaluation. Now, what is an alternative therapy if atropine fails? So I'm going to basically discuss ortho-K lenses. So what are ortho-K lenses? These are lenses which work by flattening the central portion of the cornea and steepening the mid-peripheral portion of the cornea. They are worn overnight for about constantly minimum of 8 hours, and they best benefit patients with low to moderate myopia. They are dispensed by the optometrist based on refraction and topography of the cornea. The follow-up is extremely essential for patients on ortho-K lenses. We must make sure that we see them on day 1, day 3, day 7, 1 month, 3 months, and 6 months post ortho-K prescription. On follow-up, what do we want to see? This is a pattern that we see, which is called bull's eye staining. We're seeing that the fluorescein is taking up stain in the areas of the perilimbal area and in the mid-peripheral section, which is getting edematous. And the topography on follow-up will show us that there is a central flattening and a mid-peripheral steepening. This shows that the ortho-K lens is affecting the corneal shaping. Despite knowing that this is a technology which works well, it is not extremely commonly used, and it has to be used with certain caution. And why is that? Because of the adverse effects. The most common adverse effects that are reported include tear film anomalies and disturbances in children. However, the good news is that it settles within 1 month of discontinuing the contact lenses. But we have some vision-threatening complications which include microbial keratitis, and which is why a very good counseling, patient selection would be necessary, making sure that we follow up regularly, and it is reinforced that we must see the child if there is any hint of redness, watering, pain, etc., and there's no time lost for the follow-up. So microbial keratitis is known to occur 20 times higher risk than those who use conventional daytime soft contact lenses. There is an American Academy report on using ortho-K lenses, and what they said is that the axial length elongation is reduced by about 50% over a 2-year study period. That means it is effective in controlling axial length elongation. It works better for younger children at about 6 to 8 years of age, and those children who have larger than average pupil size have better effect. Rebound effect can also occur after discontinuation or change to an alternative refractive therapy. So rebound must be still kept in mind when we are following up the child. And safety remains a concern because of the potentially blinding complications of microbial keratitis. So if not ortho-K lenses, what are the additive therapies that we can look for? Additive therapies is what we look at synergy. So we want to use methods that are going to work on different pathways that cause myopia progression. So if we look at all the pathogenesis that has been discussed, we can broadly classify them as pathway 1, which affects the scleral strengthening. It reduces the elasticity, it improves the choroidal perfusion, or it increases the choroidal thickness. So what works on this is atropine drops, and there is a newer therapy called very low intensity red light therapy. There's a pathway 2, which would cause an increase in dopamine levels. And what causes increase in dopamine levels include atropine drops and outdoor activity in daylight. And pathway 3 is using the strategy of using the peripheral defocus reducing strategies. Now this peripheral defocus, hyperopic defocus which is occurs due to multiple causes, including our binocular vision anomalies. So everything is treated with ortho-K or DIMS lenses or peripheral defocus lenses or multifocal contact lenses that are available. So there have been a recent study which is a 2-year-old randomized clinical trial which looks at combined therapy for low dose atropine. So this is 0.01% atropine along with ortho-K lenses. So what they did is they looked at 2 groups, one group which was using monotherapy only ortho-K, and the other group which was added on atropine low dose. And it showed that there was an axial length elongation which was reduced in the combined therapy versus the monotherapy group. However, it is more effective in patients with lower myopia, that is up to 3 diopters, than moderate myopia. So I'm not very sure exactly how this is going to work, but when we are looking for alternative therapies, we will have to look to alter and add when we do not have any other resource to look for. There is another study which is looking at the combination of low dose atropine, which is 0.01%, along with a peripheral defocus soft contact lens. So this was only a case series of 3 children, and these 3 children were progressing at the rate of about 1.12 diopters for the last 3 years. And these children were then started on this combined therapy using daily disposable MySight lenses, which are newer lenses. They work on spherical peripheral defocus theory, and progression in these children was, all the 3 children was reduced to 0.25 diopters in the subsequent year. That means the peripheral defocus contact, multifocal contact lenses along with low dose atropine also worked. So for those children in whom we cannot use a 1% atropine because there is an allergy or they are not tolerating it, we can consider shifting or stepping down to a low dose atropine and adding another therapy, which include either ortho-K and or peripheral defocus contact lenses.
Dr. Pooja, you have about 2 minutes.
Sure. So I would like to go through our experience at the clinic. This was at Jyotirmay Eye Clinic, and I would like to thank Dr. Mihir Kothari for all these patients. These are all his patients that I'm talking about. There were 140 children of progressive myopia who were on 1% atropine with progressive addition lenses that were seen from 2015. We've analyzed the data up to May 22. Out of 140, only 12 children were progressing on 1% atropine. That is about 8% children were failing to be controlled well. The average age was 13.5 years. That means these children were older. 6 out of these 12 children showed no progression after changing the frequency or dose of the atropine used. So 50% of this 8% did well by altering this 1% dose. So what was done? For 2 children, the dose was shifted from HS 1% atropine to morning dose, and they stopped progressing. For other 2 children, LDA was added, or a low dose of 0.01% was added in the morning along with bedtime 1% atropine. And 2 children used atropine 1% twice in a day, and they've stalled progression. There are 4 children whose follow-up is awaited. 1 child showed failure because the child had photophobia, so we had to step down to LDA, and we've started the child on DIMS as well. And 1 child had to discontinue atropine because of allergy. Looking at newer therapies, there is a newer study which is a multi-center randomized control trial to look at low-level red light therapy, wherein 264 children were treated with therapy using red light of a specific specific wavelength, that is 650 nanometer, 1600 lux, and they were used to expose this light on the screen at home under parental supervision for 3 minutes a day, twice a day, with a minimum interval of 4 years, 5 days a week. Now there was an interventional group which used single vision glasses and red light therapy, and the other one used only the single vision glasses. It shows some proof that there is some progression that is limited, however, and no severe adverse effects are reported, but we are not sure of how well we should take this study in the light of adverse effects that may be showing up later with red light. Other therapies to look out are going to be altering the illumination at home, VLRL, role of vitamin D3, and caffeine supplements in the future. So should I just take this or? Yeah, okay. So in summary, first we need to look for whether there is a drug failure or a drop failure. We need to reinforce on lifestyle changes. It is very critical that we tell the patients at every visit, because the children need to hear it from their doctor. The parents are always bantering them about their lifestyle changes. Binocular vision assessment should be looked for in patients who are having accommodative lag. Until more evidence is available, we can use the current knowledge of the pathways that cause myopia progression to add additive therapies. Stepping up the dose of 1% atropine to multiple times a day also helped in our patients. And even if progression is not halted completely, they may still be slower progressors than they are going to be without the atropine altogether. So do continue atropine drops and very gradually keep tapering it to make sure that we do not look at the rebound effects adversely. Thank you so much. I would like to acknowledge everyone who helped me in the presentation, and thank you.
Thank you, Dr. Pooja. So this actually is all the topics we have on myopia. We also have a keynote talk just now. We'll still have some time of about 5 to 7 minutes in the end to take questions on myopia, so please hang around. So I now would like to invite Dr. Vaishali Une. She's the head of department from SBH GMC Dhule, and she's going to be speaking to us on MED.
Good morning, eminent people on the dais and off the dais, and just coming in between the myopinized and atropinized topic. A small break, I'll go to the strabismus. I just want to know, I see a few familiar faces. How many of you in the audience as pure strabismologist? So that will depend on the duration of my lecture, how fast I go. So yes, let me begin. I'm going to talk about managing MED, that is monoocular elevation deficit. And most of us know that it is characterized by unilateral defect in elevation. Earlier it was known as a Duane's elevator palsy. So it is a misnomer because it is not caused by inferior oblique or superior rectus muscle paresis, but it is MED can also be associated with the jaw winking phenomena. It is present in only 0.5% amongst the strabismic patients and can be either congenital or acquired. 25% of the cases have true ptosis, meaning that there is a elevation, the globe problem also and the lid problem also. There is ptosis associated with it, whereas 75% cases are just of the pseudotosis, that is because of the hypertropia. The lid follows the eyeball. Clinical features: altered head position, that is the chin up, and large hypertropia in primary position. When the eye is fixing with the normal eye, we have pseudotosis and hypertropia in the affected eye, whereas when it is fixed with the peritic eye, the ptosis disappears and hypertropia is seen. Bell's phenomena is also noticed, and there is concurrent strabismus in few patients. So just I want to show a small video on the jaw winking, Marcus gun jaw winking phenomena. Here we see the ptosis, here we see the hypertropia, and when the child is opening and closing the eyes, we can see the movements of the lid. Etiology, I'll fast go through it because most of it is theoretical. It is secondary. There are three various views about elevator muscle paresis. Then second is due to the inferior rectus muscle restriction, and another one is third is about the combination of the both, where all the two mechanisms are involved. In acquired causes, we have CVA due to secondary to hypertension and thromboembolism phenomena. There can be mid-brain tumors, psychosis and syphilis, and also post-traumatic we can have a monoocular elevation deficit. The most important test we have to do is the cover test and the force reduction test. So why I'm stressing it on the cover test, because once you cover the normal eye, you will see if there is pseudotosis, the ptotic eye will elevate, and then you won't see the ptosis anymore, and there will you are less likely that you will refer the patient to the oculoplastic surgeon. So it is more of concern to the strabismologist. Force reduction test is, I'll skip this video. So differential diagnosis, we have the various syndromes, inferior oblique palsy, Brown syndrome, superior oblique overaction with the A patterns. Vertical duans can occur where there is globe retraction in down gaze. And blowout fracture, you need to be aware, especially students who are doing their residencies. So what is the treatment management? Yes, need is do the surgical correction, and surgery is indicated if the child has amblyopia or significant cosmetic chin eye elevation. We have to rule out whether the child has true ptosis or pseudotosis, which I have already mentioned earlier. So the plan is customized. If there is most important first thing I would like to stress for the, especially if the residents of LOs who are there, that most important is doing the cover test, find out whether it is true ptosis, pseudotosis. Second important test is the FDT. So if the force reduction test is positive, and if you find that there is inferior rectus tightness is there, if you recess it and there is element of true ptosis, then you can do the ptosis correction, either LPS resection if it is working well, or the sling surgery. If it is FDT is negative, there is no restriction, you can do the NAP surgery, the ptosis correction with, and again if the element of true ptosis is there, you can do the LPS and the sling surgery. In jaw winking, which I showed the video, you can do the naps and then either go for the crest spectacles or disinsert the LPS and then do the sling surgery. What is the naps procedure? For the uninitiated, we transpose the horizontal recti to the superior recti or vertical recti so that hypotropy element is corrected. I will like to show a augmented naps procedure. I acknowledge Dr. Shubhangi ma'am for giving me this video to show it to you. In short, I will just show that the horizontal recti are identified and sutured, and we disinsert because we are going to transpose the horizontal recti to the vertical recti. So this has been identified and cut, and now this is another medial recti. Lateral rectus, again identified, we have taken the sutures, beautifully done surgery by Dr. Shubhangi Bhave ma'am, and now we will identify the superior recti muscle, we hook it, and then we place the horizontal recti beside the superior recti muscle, we suture it here so that this is done to correct the hypotropia, and also the elevation is helpful. And then why this is augmented, because here we have to take 8 millimeters away. Yeah, this is 8 millimeters away, and here another suture is taken to reinforce the surgery. So again same for the other recti, it is sutured beautifully, and then this suture is taken to reinforce that. So this becomes an naps, augmented naps. If you don't take these sutures, it will just become, yes, this suture is most important, and yes, a clean surgery. So my talk is on the recent advances. So basically the surgical methods are the naps, modified naps and the augmented naps. And nowadays, if we have done already the inferior rectus recti during along with the contralateral superior rectus or inferior oblique surgery also are tried. There are various studies. In case of superior oblique overaction, along with the MED, we can do a NAPS procedure, and it was combined with a superior oblique tenectomy to reduce the overaction done by Bandyopadhyay et al. And in cases associated with horizontal deviation, the resect procedures along with NAPS is done. Where the deviation is within 30 prism diopters, only resection is preferred rather than recessions. So take home message is that in all cases of ptosis, examine the eye for evidence of hypotropia. We have to snatch these patients from oculoplastic colleagues. Do the cover test, examine the extraocular muscles in details, and FDT is important for your plan of action for the surgery. Customize each case and plan accordingly. Thank you for patient listening.
Thank you, Dr. Une.
Yeah, and continuing with the myopic,
Sure.
One word is, I would like to, the basic thing I would like to tell all our my colleagues is that ask your patients to have more outdoor activities, rest. Everything has been detailed so wonderfully by the team. Each and every aspect has been covered. Congratulations.
Thank you. So I'll just, I'm going to open it up to everyone just for any questions you may have in myopia. In atropine use or anything related to myopia. I just want to know how many of you are prescribing atropine routinely? Okay, so that's a very big number. And when ma'am asked how many of you are doing strabismus, there was one person who put up their hand. So clearly we all need to know enough about this, and we need to know as much as we can so that we're doing the right thing. So how many of you actually would monitor the rate of progression before you start atropine? Let's see hands. Okay, so fewer hands there, fewer hands. So it should be equal. So I'm just speaking a little bit, but whoever has questions, just be ready with your questions. Yes, and one last thing I want to ask is how many of you would do a cycloplegic refraction at some stage before starting? Good. Because everybody's subjective refraction is different. And you may just presume that this is progression. So please don't do that. Yes, please, questions. Please, go ahead.
So the difficulties that I've been facing presently is
Yes.
that there was a lack of follow-up over the last 2 years. Yes. A lot of people found it difficult to come out or were scared to come out. So I had a child coming in who had -5 diopter myopia, both parents myopic. So I was wondering, whether I need to wait for the progression, to study the progression. In fact, I had called Siddharth about this.
I think we had a conversation about it.
Yeah, we had a conversation.
Yeah, so when both parents have high myopia and the child suddenly got a high number, I wouldn't wait.
Yeah, we didn't wait, but the fact is, how do I now know whether, I just see that there's no progression or something like that.
So you will have to benchmark it against your baseline refraction now.
Yeah.
That's it. Yeah.
And the second thing is, since he is 5 or 6 years old, I'm looking at very long.
Yes. But you can give it for 5 years.
Yeah, so would it eventually possibly be possible to use it for 10 years or so?
Possibly. Once that data is there, by that time we'll have that data. Yeah. Yep.
Hello. Yeah, so I want to know that are there any factors, so what factors will you consider when you're giving atropine? When would you want to give an additive therapy? So age, myopia, family history, there have to be certain, so if I know it's over 6 and I don't want further progression, should I start an additive therapy along with the atropine if I see a progression in 6 months or 1 year?
See, the thing
what are
is,
the factors?
thing about myopia control is start early. So don't wait for it to become 6. Yeah, I'm getting to that because you said now he's 6 and I don't want it to progress. Yeah, so the point is that you start it as early as possible. Additive therapies, again, all additive therapy are symbiotic relationship. There is no, because everything is working on a different pathway. So your atropine is working on a different pathway and your progressive lenses are working on a different pathway and your DIMS is working. No. It's a call that you can take right at the onset. Yeah. So if you want to, you have to decide. No. you can be aggressive and start with DIMS and atropine together. That's okay. That's nothing wrong with that. Yeah.
So wonderful presentation. So I'll quickly ask my question. It's on the concept of pre-myopia. I would like to know your opinion on what do you consider as pre-myopia, because there are some kids who are young with parental myopia. We know both the parents are myopic, but they're still in the plus. What I have observed is over a period of time, I see if a +2 becomes a +0.75, then is there a reason to start atropine at that point itself, even when they are right there in plus? What is your opinion on that?
Yeah, so if my opinion is, as of now, we don't have enough data to treat pre-myopes, but eventually looking at the family history and the siblings, you might have to. As of now, it is not the practice pattern.
Dr. Gupta, please.
Yeah. Till what age you advise giving atropine?
Yeah, so most of these studies they have done up till 14 years of age. So 14 and 15 is around the range where we feel that growth sort of tends to slow down. So that's a rough sort of age. Please go ahead.
My quick question in continuation to Shruti's. So you keep saying early usage, early start.
Yeah.
So but and up to only 14 years, right? But there is a growth spurt which can happen in teenage. So do you feel that you should kind of reserve atropine because only maximum 3 to 5 years we can use it? Is that a concept?
I think it's just close follow-up. So even if you go 3 to 5 years, you can take a washout period, again calculate the rate, and again restart.
It's like exhausting the option. Does that?
So you want to use it like the trump card? Yeah. So it's because you have so many treatment options now. You can actually kind of choose and pick whichever you want to start early. But the whole idea is to have the idea not to leave the myopia alone. So now you have an optical option, you have a therapeutic option. So sorry, pharmacological option. You can juggle around with it. Yeah. There is no hard and fast.
We have got 1 minute, so we're taking the last question.
Yeah. Thank you for the opportunity. Just I want to ask the panel whether you are using any tool to predict how much myopia the child is going to develop. Like we have software.
There is a tool. There is a risk factor. Sort of a table where certain amount of points are given for family history, certain points are given for so you can judge the risk factors and then realize if the score is high, but it's not a standardized tool.
There is a website, Brian Holden Foundation website. You have a tool on that. You can calculate the risk progression.
But can we, like I had checked in 1 or 2 of my patients, but whether we can check for enormous every patient, can we do like that?
So there is this
BHVI for every patient.
Okay, I think we'll have to stop there. I'm so sorry. We'll take the question just informally as we step down. Thank you very much. Thanks for being so patient. Thank you.